And welcome to Itentive's webinar on the Meaningful Use Relaxation Rule. This is the 7th installment of our weekly webinar series, and with such a timely topic, we hope you find this information beneficial. Thank you for bearing with us on the date change. I'm happy to report that everyone on our team is feeling healthy again. My name is Chelsea Lukens, and I'm the Marketing Communications Coordinator for Itentive. I would like to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. Next, I'm pleased to announce that our next webinar will be on Thursday, March 12th, and it'll be on the features and benefits of NextGen UD2. We hope to see you there at noon Eastern Time. At the end of the presentation, we will open the floor up to questions and comments from you. We will answer all the questions at the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. We truly are excited to hear your thoughts and questions on this topic. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box so we can resolve them, and again, questions may be entered in the questions box. Finally, I'd like to introduce our presenter for today. Cynthia Kincade is Vice President of Consulting Services at Itentive and a Certified Practice Management Executive. With over 25 years in IT healthcare industry and 8 years with Itentive, her experience runs wide and deep, making it possible to provide the insights needed to help healthcare organizations experience great success, no matter what the challenge is. She is a recognized leader in the industry and has frequently been speakers at both UGM and MGMA. Cynthia, I'm going to go ahead and pass the webinar off to you. Feel free to get started when you're ready.
Hello, everyone. First of all, again, I'll also thank you for attending after the reschedule. I was just feeling not good this week at all, and I'm happy to report that other than being cold in Ohio, I am feeling much better. I hope everyone else out there is. There's a lot of things going around. Today we're going to talk about the CMS Meaningful Use Relaxation Rule, should you relax. And I'm going to start with some recaps. We're going to move into the measures, talk a little bit about meaningful use, and also talk about some of the new legislation being proposed. First of all, we'll start with the Meaningful Use Relaxation recap. What is it? Basically, it's the flexibility rule, and the Department of Health and Human Services published a final rule on 8/29/14 that allows healthcare providers more flexibility in how they use their certified electronic health record technology to meet meaningful use for an EHR incentive program reporting period for 2014. The reporting period is ended 12/31, and you must have all of your measures reported by February 28th. So what did the rule change? The CMS 2014 CEHRT flexibility rule allows providers to meet Stage 1 2013 or 2014 or Stage 2 2014 of meaningful use with EHR certified to the 2011 or 2014 edition criteria, or a combination of both editions for an EHR reporting period in 2014. I think everybody on this call probably understands or is familiar with this, or perhaps has taken advantage of it, but we will kind of recap it. So the details, it acknowledges industry-wide challenges with 2014 CEHRT. Basically, CMS understood that the rules for 2014, particularly Stage 2 reporting, was extremely difficult, and many people just were not going to be able to do it. So it allowed flexibility for providers unable to fully implement the 2014 edition certified EHR technology. Now, that doesn't mean that you weren't on an EHR. I think most everyone on this call was on an EHR, is on an EHR, and has been on an EHR. What it meant is that there were so many new changes to the EHR technology that even if you had a certified vendor, they might not have been able to develop or get the releases, upgrades, enhancements out to you quickly enough to be able to meet it. Providers must attest to this inability, and it must be due to delays in availability of the 2014 CEHRT. I believe most of the people on this call are NextGen, and NextGen absolutely has a letter that they will provide to you to state this. So what was the impact? Basically, if you were doing Stage 1 in 2014, you had the ability and have the ability until February 28th to attest using 2013 Stage 1 objectives and measures. That's using a 2011 edition CEHRT. And in NextGen words, that's anything 5.8 lower than UD1. If you have UD1, you must use 2014. We'll get to that in a moment. Anyone below that, you have that ability, as well as KVM 8.3.5, I believe it was. The real criteria, though, is UD1. basically, if you are using a 2011 or 2014 edition CEHRT, which many of you who had NextGen and perhaps upgraded to UD1 sometime mid-year, you could use this 2013 Stage 1 Objectives and Measures or 2014 Stage 1 Objectives and Measures. And that's for Stage 1 in 2014. Now, that seems a little strange, but what that meant was, let's say you upgraded to UD1 in August. If you had met meaningful use under the Stage 1 Objectives and Measures in January, February, or March, April, May, or June, you would still be able to legitimately certify using 2013 measures. And if you went and felt you met this, you could also use 2014 measures if you felt that you were able to do that. And then if you had a 2014 edition CEHRT, meaning that you went up on UD1, or perhaps you just began using NextGen and your only version was a UD1, you must use the 2014 Stage 1 Objectives and Measures. If you were testing for Stage 2 in 2014, and this is where a lot of confusion came in, you were ready for Stage 2, we knew it was going to be a 90-day reporting period, and it was on a calendar reporting period or calendar quarter. Basically, you were still going to need to upgrade, get prepared. However, what they found is that those objectives were so onerous, they allowed you even to attest for Stage 2. And it's really important, you are still attesting for Stage 2, but you are attesting for Stage 2 using the relaxed Stage 1 Objectives and Measures. Depending upon which version of an EHR you had, 2011 or 2014, the same applies. You could attest for 2013 Stage 1 Objectives and Measures, even at Stage 2, or 2014 Stage 1 Objectives and Measures, or if you're ready and you had it, you could already go and use the Stage 2 Objectives and Measures. And there are some people who did that because if you were in a position to do it, your providers were involved and engrossed in the workflow, why would you go backwards? And then last but not least, if you were always on a 2014 edition, you could use 2014, but instead of Stage 2 measures, you could revert to the Stage 1 measures. So valid reasons to use the FLEX rule. Basically, it was due to late certification. Many of you weren't able to upgrade to UD1. Many of you, UD1 didn't come out. There were a lot of repeated upgrades. There were software installation difficulties with performance. Not all of these are acknowledged and basically, accepted by NextGen, and that's why they've been so forthcoming. Everyone was happy about this. Software issues that required costly and time-consuming manual corrections, patient safety concerns, a negative effect on productivity, record accuracy, and overall EHR operations. I think anyone who was dealing with some of the changes that occurred and weren't able to overcome them in a timely fashion recognizes that this applies to most everyone, and I'm sure everyone on this call. There are some invalid reasons to use it. Failure to pay for upgrades or ancillary products. Basically you couldn't say that you wouldn't do it because you didn't want to spend the money on the portal. Failure to take upgrade in a timely fashion. Failure to meet thresholds for the 2014 objectives and measures for your scheduled meaningful use stage. What that means is that you had everything in place, which most people didn't anyway, but if in case you did have everything in place and you just didn't do it, well, that doesn't meet the criteria. So who was eligible? While the rule states only providers who have been unable to fully implement 2014 CEHRT can take advantage of the rule's flexibility options, pretty much everyone qualifies because of the reasons I cited. And were there other benefits to this rule? The rule also finalizes the extension of meaningful use Stage 2 through 2016, and it extended the Stage 3 timeline, which will begin in 2017 for providers who first become meaningful use EHR users in 2011 or 12. So for those of you who have been participating since 2011, you would have begun to need Stage 3 in 2016 because they're not ready for that. They have extended it beyond that. So here are the changes to the timeline. And going back to those of you who attested in 2011, basically this moves your 2016 Stage 3 to 2017. And the same applies for those of you in 2012. For those of you who were 2013 and 14, which is where we're at today, it really doesn't show an extension, but it really moves it out to 18 instead of 17 in here. So basically it has moved it out to everyone to give you a little bit of an extended timeline for moving into the Stage 3 meaningful use. And once this happened, we all breathed a sigh of relief, danced a happy dance, and went off to enjoy the holidays. I can tell you when we got the news about this, and I know some of you that are on the call are people that we have worked with, everyone was happy. It was a relief. It gave everyone some breathing room, and during a time when we all were really ready for some breaks. So now it's 2015. And we begin to see the fine print. For some of you who attended some of the earlier webinars we had, we talked about some of these things that I'm going to talk about now. So we see the fine print, or perhaps we at least understand the fine print, because it wasn't hidden. It was just out there. I think a lot of groups that I've been speaking to since this happened were so pleased with it that they really just wanted to take advantage, and really now we need to think about where we are at today. First of all, this was not a delay. All upgrades still occur. The flex rule was intended to give you more time to upgrade and acclimate your providers. Year 2, Stage 1, and Stage 2 are upon us. They didn't go away. If you were attesting, even though you might have been using Stage 1 rules and you were in Year 2, you are in your second year of Year 2. If you just happened to do your Stage 1 first year, you are now in your second year of Stage 1. And if you were in your full year, even though it was a 90-day of Stage 1 last year, you are now in Stage 2 this year, which is also a full year. So 2015 requires attestation for the full calendar year for both Stage 1 and Stage 2. And we're already in the mid-February. You must now use the more challenging 2014 measures for Stage 1 and Stage 2. Remember, the 2013 was a flex. That was a one-time option, at least at the time. That's what they said. And there was no relaxation in penalties. So the penalties still apply, even though perhaps you were able to attest for 2000 or are attesting for 2014 using a lightened measure. The meaningful use Stage 1 requirements. So I'm just going to recap on the requirements. All 13 core measures must be met. 5 out of 9 of the menu measures must be met with at least one public health measure included, and at least one public health measure included must be met. 9 out of the 64 CQMs covering at least 3 national quality strategy domains must be met. If you're at Stage 2, all 17 core measures must be met. 3 out of 6 of the menu measures must be met, and 9 out of the 64 CQMs covering at least 3 national quality strategy domains must be met. What I decided to do is I think everyone that's on this call, or who at least had registered, has a familiarity with meaningful use. But I'm just going to pick out a few of the measures, particularly some of those that I find pretty hard and difficult to meet. So we're going to talk first about core measure 6, which is clinical decision. The objective here is to use clinical decision support to improve performance on high priority health conditions. So measure 1 is implement 5 clinical decision support interventions related to 4 or more clinical quality measures at a relevant point in patient care for the entire EHR reporting period, which in this case is a year. Absent 4 clinical quality measures related to an eligible provider's scope of practice or patient population, the clinical decision support interventions must be related to high priority health conditions. Measure 2, the eligible provider has enabled and implemented the functionality for drug-to-drug and drug allergy interaction checks for the entire EHR reporting period. The exclusion. For the second measure, any eligible provider who writes fewer than 100 medication orders during the EHR reporting period. So basically, you can get excluded from Measure 2 if you meet this criteria. The positive aspect about this is this measure only requires a yes or no answer. You have to implement the decision making. You don't have to necessarily demonstrate how many, et cetera. It's just yes or no, you are doing it, and must be able to document that you have done it. Core measure 7, patient access. This is one that I find particularly challenging. The objective is to provide patients the ability to view online, download, and transmit their health information within 4 business days of the information being available to the eligible provider. For those of you, I'm going to talk a little bit about this, for those of you who are using 2014 Stage 1 criteria or Stage 2, you have already met part of this because of the fact that that was still a measure in 2014. The difference was it was only for a quarter. And if you stuck to Stage, in both cases, it was only for a quarter this year. This time it's going to be for the full year. So Measure 1 is that more than 50% of unique patients seen by the eligible provider during EHR reporting period are provided timely, and that means available to the patient within 4 business days after the information is available to the eligible provider, online access to the health information with the ability to view, download, and transmit to a third party. Now, for those of you who are using NextGen, this is the patient portal. For many other practices, it's also a patient portal. Most of the systems have these. Some of the things that can be helped is now you've got your auto-enrollment, your bulk registration. That will help you get to the 50%. However, Measure 2 is more than 5% of all unique patients seen by the eligible provider during the EHR reporting period or their authorized representatives view, download, or transmit to a third party their health information. This is out of your control. We have to educate our patients. We have to get our patients to do this because the bottom line is it is patient participation and patient engagement, and that's a challenge. It's a bit out of everyone on this call's control, and I'm not sure how to do it. We've got ideas. We've helped some people there. The bottom line is this was one of the relaxed areas. It's not relaxed, at least as it exists today. So there are a couple of exclusions. There's exclusion 1, any eligible provider who neither orders nor creates any of the information listed for inclusion as part of both measures except for patient name and provider's name and office contact information may exclude both measures. Exclusion 2, any eligible provider who conducts 50% or more of his or her patient encounters in a county that does not have 50% or more of its housing units with a 3 Mbps broadband availability according to the latest information available from the FCC on the first day of the EHR reporting period may exclude only the second measure. Now that sounds really easy to prove to me. And honestly, I think that you can probably get with your local areas, but clearly it's a rural area and that doesn't apply to many of us. Core Measure 9, Security Risk Analysis. The objective of this is to protect electronic health information created or maintained by the certified EHR technology, CEHRT, through the implementation of appropriate technical capabilities. This measure is conduct or review a security risk analysis in accordance with the requirements under 45 CFR 164.308A1, including addressing the encryption security of data stored in a CEHRT in accordance with requirements under 45 CFR 164.312A2 IV and 45 CFR 164.306D3. And I wonder how many on this call have actually read those requirements. We have individuals who have. I personally have not. I can tell you they are more onerous than they were in the 2013, and they have taken it a level beyond. So if you have a security risk analysis that's already in your meaningful use binder, that needs to have been redone in 2014 or will need to be redone if you are using 2014 this year, and make sure it's in accordance with these regulations. And once you've done and once you understand them, you must implement security updates as necessary and correct any identified security deficiencies as part of the provider's risk management process for eligible providers. That could be pretty scary, and there's a lot of different moving parts to this one. And again, for those of you who are on the call, if you have any questions about this or would like to talk about it, we can certainly email me. We can maybe get you some information on it, and then we also have some services that we can take you through this if you're interested. However, now we'll move on to Core 15, transitions in and out of care. The objective for this one is the eligible provider who transitions their patient to another setting of care or provider of care or refers their patient to another patient of care should provide summary care records for each transition of care or referral. Note, the eligible providers must satisfy measures 1 and 2 in order to meet the objective. Measure 1, the eligible provider who transitions or refers their patient to another setting of care or referral of care provides a summary of care record for more than 50% of the transitions of care and referrals. Measure 2, the eligible provider who transitions or refers their patients to another setting of care or provider of care provides a summary of care for more than 10% of such transactions and referrals, either A, electronically transmitted using the CEHRT to a recipient, or where the recipient receives a summary of care record via exchange facilitated by an organization that is a NWHIN exchange participant, or in a manner that is consistent with the governance mechanism ONC establishes for the NWHIN. Now what that means is you have various HIEs in many of your states and areas. We also have Next Gen Exchange, and then you have the Continuity of Care document. All of these answers and all of these solutions are available to you, and they will require some form of interface, be it if you're next-gen share, some of the items that you would be moving forward with, and options to do. So those must be in place, and that is something that we've seen a big increase of requests as it relates to NG Share. On a positive note, NextGen has made available NG Share, and if you're on the proper versions, which it requires UD1, then you can utilize that, and you don't incur an extra interface charge. Otherwise, you've got NextGen Direct and some other areas that you need to take care of. There is a note: an eligible provider must satisfy one of the criteria under Measure 3 to meet the objective. Measure 3 only requires a yes or no answer. Measure 3, conduct one or more successful electronic exchanges of a summary of care document, as part of which is counted as Measure 2. Now, this probably needs a little graph to explain, but basically what they're saying is that you have to do a Measure 3, which is conduct one of those things, and that can be used as Measure 2. For an exclusion, any eligible provider who transfers a patient to another setting or refers a patient to another provider less than 100 times during the EHR reporting period is excluded from all 3 measures. And I do believe that there are probably some individuals, particularly depending on your specialty, who may actually be able to meet this exclusion. Core Measure 17, patient engagement. Again, this is the patient engagement portion, which is very challenging because it's not entirely in your control. So the objective is to use secure electronic messaging to communicate with patients on relevant health information. A secure message was sent using the electronic messaging function of CEHRT, or your portal, by more than 5% of unique patients or their authorized representatives seen by the eligible provider during the EHR reporting period. The exclusion would apply if any eligible provider who has no office visits during the EHR reporting period, or any eligible provider who conducts 50% or more of his patient encounters in a county that does not have 50% or more of its housing units with the broadband availability that we mentioned earlier. I won't go through the whole FCC thing again, but basically rural areas. And I'm only going to show one menu measure because this is one that has been out. You must, as we mentioned, depending upon whether you're Stage 1 or Stage 2, utilize a number of menu measures in accordance with the stage requirements. The objective here for the syndromic surveillance is to capability to submit electronic syndromic surveillance data to public health agencies except where prohibited and in accordance with applicable law and practice. This measure is successful ongoing submission of electronic syndromic surveillance data from CEHRT to a public health agency for the entire EHR reporting period. And the message here is ongoing. This is also a menu option. Exclusion. The eligible provider is not in a category of providers that collects ambulatory syndromic surveillance information on their patients during the EHR reporting period. Exclusion 2, the eligible provider operates in a jurisdiction for which no public health agency is capable of receiving this type of data. Exclusion 3, the eligible provider operates in a jurisdiction where no public health agency provides information timely on capability to receive syndromic surveillance data. And exclusion 4, the eligible provider operates in a jurisdiction for which no public health agency that is capable of accepting the specific standards required by CEHRT at the start of their EHR. So there's quite a few exclusions to this. Unfortunately, depending upon where you are, most of them do not apply, at least for the groups that I work with in Ohio, New York, Indiana, Florida. All of them have these areas in there, and this is another area, again, that might be useful with NextGen Direct or NG Share. So just taking a look at those, as you can see, they're still pretty encompassing. There's a lot to do, and we, in theory, right now have to do it for the full year. And on top of that, then there are the penalties. So the penalties are, as part of the American Recovery and Reinvestment Act of 2009, Congress mandated payment adjustments to Medicare-eligible professionals, eligible providers who are not meaningful users of a certain EHR. The payment adjustments begin on January 1st, 2015, and increase incrementally for several years after. The payment adjustments will be applied to the Medicare physician fee schedule for covered professional services furnished by the eligible provider during the year. The payment adjustments are based on a 2-year look back. And for the purpose of this presentation, I'm only focusing on the Medicare penalties. The Medicaid penalties are slightly different timelines. They are still, unfortunately, penalties, and they are still in effect regardless of whether you're taking advantage of the flex rule. Patient adjustment amounts. Basically, I just looked at this. The payment adjustments, avoid Medicare Part B payment adjustments in the future. You have to continue to demonstrate meaningful use every year. As mentioned, it's a 2-year look-back. If you are eligible for Medicare and Medicaid, you must demonstrate every year. And if eligible for Medicaid only, you are not subject to adjustments. So what that means is if they'll only have Medicaid only, you're not subject to the adjustments in this time frame. So we'll talk a little more about that. In 2015, which is the first year, you basically are going to incur, if you have not met the criteria, you will incur a 1% penalty. In 2016, 2%, and subsequently through each year up to 5% in 2020 plus. And while I'm not covering that in this slide, we are going to talk a little bit or make some references to PQRS because the PQRS penalties are also starting this year. So who will be penalized for meaningful use in 2015? You are not subject to a Medicare Part B adjustment in 2015 if you answer yes to either of the following questions. Did you attest for meaningful use in 2013? Remember, it's a two-year look back. So if you attested successfully in 2013, you will not be penalized. Or if you were a first-time provider in stage 1 doing your 90 days, were you an eligible provider attesting during the first meaningful use participation year of 2014 and successfully submitted the attestation prior to October 1st, 2014? What that means is, again, if you were only attesting for the first time and you had not successfully attested in many years, you had to do it successfully by October 1st, which meant it would be the July, August, September timeframe attesting for July by October. You could still have attested October, November, December and received that final small payment that was coming out. However, you would still be penalized. It had to be done by October 1st. If you answered no to both of these questions, meaning that you did nothing in 2013, it didn't matter if it was your first or second year of stage 1, or you answered no and you were not a first-time provider and did it in 2014, you will be subject to the 1% payment adjustment. So who will be penalized in 2016? You will not be subject to a Medicare Part B adjustment in 2016 if you answer yes to either of these questions. Did you attest for meaningful use in 2014, or are you going to attest by February 28th? Were you an eligible provider attesting during the first meaningful use participation year of 2014 and successfully submitted the attestation prior to October 1st, 2014? If you answer no to both of these questions, you are subject to the 2016 2% payment adjustment. So this is a little known penalty fact. At least it's one I didn't know. Maybe everyone on the call did, but this was something that as I started looking at this really to prepare for this presentation, I just hadn't paid a lot of attention to it, that eligible providers will receive the payment adjustment amount that is tied to the year they did not demonstrate meaningful use. So if you go back to that graph, 2015 is 1%, 16 is 2%, 17 is 3%, etc. So for example, a provider who is eligible for a payment adjustment in 2018, meaning if you don't achieve meaningful use in 2016, you will receive a 4% PFS reduction regardless if this is the first year or fourth year not demonstrating meaningful use. You will be eligible for the 4% penalty even if you have completely attested all the years prior to the year that is criteria for 2018. Now you would also, if you haven't ever done it, you would have the 1%, the 2%, the 3%, so you would have the escalation. However, you don't start with 1%. So this is no time to relax. Or is it? Basically, CMS intends to modify requirements for meaningful use. So there's an excerpt from the CMS blog. Today, we, the Centers for Medicare and Medicaid Services, are pleased to announce our intent to engage in rulemaking to update the Medicare and Medicaid electronic health record EHR incentive programs beginning in 2015. These intended changes would help to reduce the reporting burden on providers while supporting the long-term goals of the program. Since the first year of EHR incentive programs in 2011, the United States has seen unprecedented growth in the adoption and meaningful use of EHRs. To date, more than 400,000 eligible providers have joined the ranks of hospitals and professionals that have adopted or are meaningfully using EHRs. This means that millions of patients across the nation are benefiting from the potential of better coordinated care among professionals, more accurate prescribing, and improved communication. The new rule expected this spring would be intended to be responsive to provider concerns about software implementation, information exchange readiness, and other concerns in 2015. It would also be intended to propose changes reflective of the development in the industry and progress towards program goals achieved since the program began in 2011. This is a blog by Patrick Conway, MD, and it was through the CMS blog, and it was released on January 29th. So CMS right now is considering a proposal to realign hospital EHR reporting periods to the calendar year to allow eligible hospitals more time to incorporate 2014 edition software into their workflows and to better align with other CMS quality programs. It's also designed to modify other aspects of the program to match long-term goals, reduce complexity, and lessen providers' reporting burdens, and shorten the EHR reporting period in 2015 to 90 days to accommodate these changes. Other organizations that have weighed in, and I've taken some excerpts and did quite a bit of research on this. AMA seeks alignment of the meaningful use objectives. An excerpt from EMR Intelligence article, October 23, 2014. The American Medical Association is calling on the Centers for Medicare and Medicaid Services to align the EHR incentive programs, physician quality reporting systems, and the value-based payment modifier in order that providers can avoid penalties. The quote is, physicians want to provide our patients with the best care possible, but today they are confusing, misaligned, and burdensome regulatory programs that take away critical time physicians could be spending on providing high-quality care for their patients. This is a quote from AMA President Robert M. Waugh said earlier this week. In a letter to CMS Administrator Marilyn Tavenner, the association is seeking the reversal of proposals to raise penalties for the programs by 10% or more. Now, you've heard me speak about the 5% that will come from meaningful use. There are also the PQRS penalties that are increasing each year. And for those of you who may or may not have made PQRS in 2014, the penalty is now going to be 2% for that. So if you've got a meaningful use penalty of 1% and then 2% PQRS, you're now at 3%. They are running simultaneously. They further go on to state, these programs are with often incomprehensible conflicting requirements and flawed implementation processes are all entering their penalty phases and pose a risk to the stability of the Medicare program that many policymakers do not seem to appreciate. So the AMA Meaningful Use recommendations is remove the all-or-nothing provision at the very least, make optional the measures that are most challenging for the vast majority of physicians, including view, download, and transmit, transitions of care, and secure messaging. Those are really the measures that I selected to point out to you because these requirements in many cases are completely outside of the physician's control or the provider's control. Number two, require physicians to meet one set of quality reporting requirements, meaningful use, PQRS, quality selection of VBM, but not all, and shorten the 2015 reporting period to 90 days. And then we have other groups that have weighed in. On the MGMA, on July 21, 2014, MGMA sent this comment letter raising concern over physicians' ability to comply with the second phase of Meaningful Use program due to rigorous requirements, lack of available software, and other hurdles. In the letter, we highlight several recommendations that would rectify key obstacles and create more flexibility within the program. I also checked the American Academy of Family Physicians. In fact, in February, the AAFP and 46 other organizations sent a letter to then HHS Secretary Kathleen Sebelius saying we fear the success of the program is in jeopardy if steps are not taken now to address our shared concerns. So what does Itentive think? I've told you what all the other people think. I've given some laws. I can only tell you what we think. We believe that the 2015 attestation for both Stage 1 and Stage 2 will be relaxed to 90 days based on the strong statement from the CMS blog, as well as all of the other medical groups that are weighing in. I really do believe that's going to happen, and it is, I think, based on the strength of their statement and the fact that they indicated they intend to do it, they will do it. Again, it does have to be passed. It is a measure. We also believe the requirements will be softened either by continuing to use Stage 1 measures or allowing the use of Stage 1 measures or by easing the percentage requirements of the Stage 2 measures. I do not know if they will go back to the 2011 stage 1 measures. And that's very different, and part of that has to do with the patient portal. We believe that the penalties for meaningful use will be softened, although not for those already impacted in 2015. Those who are going to be getting a penalty in 2015, I think you've already received your letters, if any are on the call. I also think that that's in place and it's not going to change. I don't know if the increase is going to go as high or quickly as it is projected. We know that there will be some form of attestation required, though. I also know that there is a risk in relying on the relaxation of the rules. I believe it's going to happen, but in the end, we are only guessing. So I guess, what do you think? And that's how I will leave it with you. As Chelsea mentioned in the beginning, we've got Thursday, March 12th at noon Eastern Time, the features and benefits of NextGen UD2. We have a number of clients that are betaing UD2 right now. It should be in release at that time, and hopefully we'll be able to give you some overviews of some of the features. There are some really, really cool features in UD2, particularly as it relates to the physician workflow and PAQ and some other things. There are also some EPM enhancements, although the workflow, I think, is just a great, great move forward. Then again, on Wednesday, April 8th, we are going to have a webinar evaluating your practice's financial health. That will be conducted by Jeannie Logue, and she will actually be taking you through some steps and things you can do to actually go in, take a look at your AR, look at how it's moving, and give you some helpful tips and tricks. And then coming soon, the truth about penalties. I'm going to wait a little bit on this one. We were kind of anxious to do it, but we're going to wait to see what happens in the spring and if there's anything coming out. But basically what we want to do is talk about the penalties, talk about all 3 of the areas where you will be getting penalties that could compile up to as high as 10%. And if you are in a penalty phase, how you can come out of a penalty phase. Those are the next 3 webinars that we have planned. Last but not least, if you need any help, we do provide EHR workflow assessments, and you can reach out to myself or to Lloyd Taylor, and we can talk to you about what those entail, what the costs are, and how they work. So now I'll just leave it for questions and comments for any of you that might be interested in adding any of your insights, what your thoughts are about what's going to happen with meaningful use, how are we going to move forward this year, are you upgrading, if any of you have positions on it, would really, really like to hear your thoughts as well as your questions.
Thanks, Cindy. And as a reminder, any questions that you have, you can type in the questions box of the GoToWebinar panel. I'll give you guys a few. Oh, here's a question. Would you please clarify? We updated to UD1 in 2014. You stated that there was still a possibility to attest MU2 with 2013 rules. Please restate those possibilities.
Okay, basically, and this is always tricky, depending upon the time that you upgraded. So let's say, for example, you upgraded, UD2 was a 90-day attestation. So that would have been January, February, March, April, May, June, July, August, September, October, November. I got that off. I'm still suffering from my cold a little bit, but you get the gist. So the bottom line is, if you took UD1 in October, you would be able, you took UD1 in October, that is the version that NextGen only attested for 2014 criteria. So let's just say, for example, then you went back and you downloaded the Crystal reports, you had the information, and you could use the softer rules. You would have to do January, February, March, April, May, June. But once you got to January, February, March, April, May, or June, you could, either one of those periods, if you pick that period as your quarter, then you could use the 2013 because you were not on UD1 at that time. Does that make sense? And because it's really hard to get that, to kind of explain that, but hopefully that makes sense. So you just pick a quarter before you went on UD1, but it has to be a calendar quarter. And I will tell you, a lot of people are looking at that because the hardest thing that people have had to meet with the 2014 criteria, in my opinion, is the patient portal, the 50% of the 4 days giving them access, even if you had the auto enrollment, which does help amazingly because it meets the criteria, particularly if you're using the stage 1. Stage 2, you actually have to have the 5% participation. However, if you use stage 1, you only had to make the attempt to get them registered. But that, to me, is the hardest one. And in 2013, using the 2011 criteria, that was a menu set measure. So you didn't have to use it. It was there. It was the same one, but it was a menu measure. And that's the one I've had the most trouble getting the people we've worked with to meet, because it's, again, it was patients, and before NextGen had the auto-enrollment, you had to give them a token, they had to register, and it was just really, really hard, even though it was only 90 days.
Cindy, follow up to that question. Could we use the quarter before we updated to UD1 as our reporting period? We went to UD1 in June.
Yes. So basically, in that case, if you went in June, you would have to do January, February, March. If you had April, May, June, it would have to be the full quarter, and if you went to it partially in June, then you're getting iffy. So if you could attest in January, February, March, yes, you could do that. You would need to get your crystal reports from NextGen, and again, the 2000, I'm going to call them the 2011, but it was the 2013 criteria. Basically, that was the crystal reports as far as opposed to the HQM.
Do you have anything else to add while we're waiting for more people to type in their questions or comments or concerns?
Right. With that particular one, if any of you have questions, my email is on the line. Email me. I'm happy to do it because it's tricky, and I don't ever want to give anyone bad advice. When I say things, yes, it's always important. It's based on our understanding, although I have had people do it. So that one I'm relatively confident about. I just want to make sure that your dates are right. Make sure you really do your homework before you take something I say as absolute gospel. Again, I'm relatively confident about it because we've had several people who have already successfully done this and upgraded at the end of the year. I think a couple of them are actually on the call that upgraded at the end of the year, but attested using the criteria beforehand. That said, make sure you get your dates right.
And I wanted to take a moment and let you know that if you want to stay up to date with our webinars or any white papers or tips and tricks we might be passing out, please do follow us on Facebook, Twitter, YouTube, and LinkedIn. And we're happy to connect and share what we know and answer questions on there too. So just friend us, follow us, whatever you want to do, we'd be happy to keep in touch more.
All right. Well, thank you all for joining. And as I said, any questions, feel free. If you want any information, a copy of the presentation, I believe Chelsea will be sending it out. We'll also be, as she said, putting it on YouTube. But in addition, if you are interested in any of the source materials, the links to some of the websites that I looked some of the information up, just to kind of go out and do some of your own validation, please feel free. I'm always happy to share. All right. Thank you, everyone, and have a great day.
Have a wonderful day and a great weekend.